All right, it is 6:05 and I will call the board meeting to order. Kyle's going to work on getting that muted online, but I will start. I'll start with public comment. We have two requests. Is Dr. Al Yusuf here?
No, I texted him and let him know I'd fulfilled his request, but I haven't heard from him.
Okay, I'll move past him for a moment and I'll move to Jennifer Briggs. Jennifer, you have 3 minutes. And Megan, am I supposed to give him some other?
I'll time.
Okay.
Yeah. We'll let you know when you have 1 minute left.
Okay, thank you. My name is Jennifer Briggs. I am currently a resident of Silverton, Oregon, although I was a longtime Coos Bay resident. My parents both live here. I wanted to come before the board today to say thank you for this. This is amazing. This is such a great resource for community members to be able to look through exactly what, to see the numbers on the paper in front of us. I also wanted to thank you very much as a board for changing the minutes. I am going to actually need to sign in online after this. I need to drive back up to the Salem area. And it is, I know that I will, if there are places where I don't catch things on the road, I'll be able to go back in the minutes and see them. I also wanted to thank Mr. Morgan for your work here and for what are actually complete and like business reports that are now recorded in the minutes. So thank you very much for that. And my last thing that I wanted to just touch on was that I heard a rumor about some of the funding that happened during the campaign, about $150,000 contributions or and just wanted to say that as part of the political action committee that worked on this project, that number is completely not accurate at all. And you can find it online with the Secretary of State. So very good. Thank you.
Thank you. And those packets are also available online before the meeting, about a week-ish before the meeting.
I already got it.
Perfect.
Yes.
Great. Well, if I have no other written in-person public comments, I'll check online. Is there anyone online that'd like to make any public comment?
I muted all the phone numbers for.
Oh,
Yeah.
They can unmute themselves. Though.
Okay.
okay. 5 more seconds. No public comment online. All right, with that, I'll close public comment and we'll move on to the consent agenda. The consent agenda is in the packet. And there should be some out in the crowd. Does anyone on the board have any questions or comments about the consent agenda? If not, I'll take a motion to.
I would make a motion to approve the consent agenda.
Second that.
We have a motion from Kyle and a second from Dr. McAndrews. All in favor?
Aye.
Aye.
Anyone opposed? Great. Consent agenda passes. With that, I will move to the report from our CEO, Kelly Morgan.
Please pull up my presentation.
Is it in here, Kelly? Okay.
So this is going to be, Mr. Chairman, a fairly lengthy report. And as I kind of walk through this, if you have questions as we go, please let me know or at the end. So been here a little bit over a month now, and every week's a little bit of an adventure with finding out additional information. So this is a little bit of a recap of what we did last month with a couple modifications, but I think it will make sense as we kind of get towards the end of it. So this is our average daily census that we shared last time. I have kind of back to 3 years. This is a little bit different from what you had seen previously. The other data that we shared last month included nursery days with OB. So actually it increased our average daily census by about 3. So this is more accurate. We talked about last month about being a 75-bed hospital. So that really is kind of where we're at for the last 3 years. When we look at our licensed available beds, so we have 132 available beds in the hospital. If you kind of walk across on the right-hand side for fiscal year 23, 24, and 25, you'll see where we've remained relatively consistent in some departments. If I take you down to post-surgical unit, we were at 10. That's where we had that drop off in volume. And then the psychiatric unit, is run from 5 and up to 7.5. And then the birthing center generally is running about 3.5 patients a day. So we've averaged anywhere from 58 to 75 patients over the last 3 years. You guys have seen this before. Again, this is just as a reminder that the $24 million that we actually lost in 25, that's our particular target. And as we start walking through our expense reduction, we're going to base it off our fiscal year 25. So that's the run rate that we're using as our baseline. You guys have all seen this also, that our average loss over the last 13 months is about $2 million a year. So that's the focus that we've had. The days of cash on hand, we have updated this. Actually, the number at the very end is not June 26. That actually is August. So that is through the first 2 months of this fiscal year. Our cash has actually dropped by 4 days. And on an aggregate basis, we're at 41.9 million. Now we're at 39.6. So we continue to see a drop on our cash. So that's driving a lot of our concerns. So just as a reminder, from June 22 to June 25, we actually spent over $60 million of cash. Our burn rate is still a little over $1 million a month. This is a little bit of an update from the Bank of Montreal. And as I mentioned, every week that we're here, there's new information that has come up. So I think everybody's aware that we have an outstanding loan of about $45 million. We are in default of the loan since we're not meeting our cash flow projections or operating margins. So our interest rate bumped up from 3% to 7%. The new information that we got late last week, and going back on the contract, is unfortunately, we also have a balloon payment that is due in 5 years. So in December of 2030, we owe the Bank of Montreal a $35.3 million balloon payment. That's part of the 45, but that puts a lot more pressure on us now. In order to meet that, we're going to have to generate, another $6 to $7 million in cash flow each year to be able to pay that. Update on Epic. I think we also talked last month that we signed a contract with St. Charles and Vend for Epic Community Connect. That contract actually expires in February of 27. We've had several different calls with the leadership team at St. Charles that their preference is that we migrate off Community Connect by the calendar year of 2027. They're fully aware of our financial issues here, so they're willing to work with us to extend that if needed. But their preference is that sooner before later is that we will actually migrate off. We've had quite a few different discussions with Epic. So Epic provided us a price last week that if we host our own Epic system, the cost of that would be $22.3 million. So that's another $22 million that we're going to have to come up with from a capital basis. So you add the 35, you add the 32, now we're talking, close to $60 million that we'd have to come up with free cash. Obviously, that is something that would be extremely difficult for us to achieve. In our discussions with Epic, we have had a pretty frank discussion with them because of the situation that we're in and the situation that we've had with St. Charles, for at least them to give us consideration to at least pick up all, if not part of that $22 million. We're also exploring with Epic of possible other Community Connect partners. So we don't have that. Hopefully over the next couple of weeks, we'll have a little bit clearer picture. But Epic is something that we have to deal with. We have to have an EHR for the hospital. Doug also put together our overall capital needs. So this is, everything that we need right now for over the next several years. These, some of them are replacement, some of it's for different business aspects, but our overall capital needs over the next several years is $61 million. We're currently on a capital, we call it break fix, so we're really not spending any capital unless we absolutely have to. These are just selected high ticket items that we have to at least be cognizant of. I'm not saying we have to do them today. Many of these are on service contracts, but several of these items are also at end of life. So take the 22 from Epic, take the 35 for the balloon payment, and then we've got some significant capital needs. It makes all of us just a little bit anxious of how we're going to fund all this. This is a brief slide, and there's been a lot of discussion feedback I've got from different people that when Civista came in, that they promised that they would actually increase our cash flow by 20 million a year. This is a busy slide, and I apologize for that, but this is apparently what Civista actually provided to us. But the reality, here's the actual contract with Civista that actually says that the threshold of the 230 million is not a guarantee, nor a promise, nor it's just a projection. So my opinion on the Civista contract, what they told us was a sales pitch. Nobody ever guaranteed they were going to increase our cash flow by 20 million. So that is something we're going to continue to work with the Civista team. There are some improvements, but the 20 million is something that is not our reality. All right, so the past month, our senior management team, as well as the middle managers, we spent a lot of time on trying to come up with what's a reasonable approach and trying to get our expense reduction. If you recall, our goal is to come up with a $30 million turnaround plan. So I do want to emphasize to the board that this is a work in progress. So this is a point in time. We are ready to proceed on with this because I don't think we can wait any longer to not, move in this direction. But we looked at all for different staffing levels. So what we identified is that a reduction of 83.8 FTEs. I will tell you that number is going to go up as we get more information, as we work through some different departments. Not all of these are actual people that will be reduced production force. Some of it's through attrition, some of it's through a core schedule, some of it is modifying hours, but overall that would be a reduction of about 84 FTEs. Looking through that, that actually is a dollar amount of about $10.2 million, which includes salary, wages, and benefits. We've also keep in mind that we're going to continue the hiring freeze. We have a goal to eliminate at least half of our travelers by 50%. We're going to try to stretch that a little bit in November. And then any staffing issues that we have or requirements, we will continue to monitor that. We've also worked through our professional and physician fee contracts, which we believe there's a $3.5 million savings. There were also many of the contracts that we still have to negotiate. Those are in different stages. Those are going to take some time, and looking at the different agreements we have, whether it's with entities here in Coos Bay or with different national firms. We've also identified about $989,000 in supply savings. Purchase services, that'd be different contracts, legal, consulting agreements. Those are also different agreements in progress. We do believe that we've identified about $3.4 million in saving in purchase services, and then just kind of the catch-all for different other operating expenses. And we literally have been through a lot of these with line by line item. So the overall annualized, I want to say annualized expense reduction is about $19,900,000. If you look at the note, some of these we can do immediately. We'll get some savings. Other are going to take 6 months or more. So trying to be a little bit, I'll come back to that. Also on revenue enhancement. So this is, our third-party payer contracts. These are the largest contracts that we have: Regents, Moda, United, Aetna, Pacific, Source, Providence, and Cigna. That we'll go back and have a negotiation with them. We also need to sit down with Advanced Health, which is the CCO. I don't have an estimated number on those yet, and each of those will be a different negotiation. So I don't want to overpromise something until we can actually complete those negotiations. Doug and his team are focused on the revenue enhancement. So this is revenue cycles. And there's a couple different areas going on here. One is the billing and collection for the hospital. So that's a strong coordination with Civista. I think everybody knows we're at least in for another 2 years and working with our partnership with Civista. We also have a lot of billing and collection for professional services that we have for hospital-based functions or departments that we have. And that's with Civista, and Coronis is actually doing the billing for the anesthesiologists. Also, over the next few months, we'll need to work very diligently with the medical community, and this has a lot to do with documentation, whether it's denials, reauthorizations, appropriate admissions, timely filing, and all of that is a lot of it's one-on-one for each individual case to try to get a better handle and get better collections. So this, I would say, is probably a conservative estimate that we think we can generate, through this particular cycle of $6 million. It possibly could be more, but realistically, because of the work that goes into this, we're projecting that this isn't going to happen until fourth quarter of this fiscal year. So this is the part where we wanted to put a little bit of a conservative estimate. So I think everybody would like a nice surprise, not a difficult surprise. So the 19.9, we're trying to be realistic, is we had a 20% discount off that because certain things that we think we can do perhaps don't come to fruition, or there's other expenses that come up that we're not anticipating. So that would bring us to about 16 million. And then because we're already into September, already several months into this fiscal year, we're going to take a 70% realization rate that we think we can accomplish between now and the end of June, which brings us to 11.1 million. As I mentioned, on the $6 million for revenue cycle, that's about a 2.5% increase in net revenue. And looking at that for the fourth quarter, we would actually realize 25%, or 1.5 million. So the expectation is that our cost savings and with revenue cycle would generate $12.6 million. Once we get to July 1st, that the annualized rate would be close to 22 million. Now, keep in mind, this is from an expense standpoint on our baseline of fiscal year 25. This doesn't include anything that we're expecting of what's our expense structure going to look like next year. So just to kind of keep in big picture, so this is at 5,000 feet. If we had a 4% increase on our expense structure next fiscal year at a budget of about 250 million, that's another $10 million we're going to have in expenses. So this is, I will say, is kind of a one-time thing that we got to keep working on that. So we still got a ways to go to the $30 million. And right now we're short of that. Couple that with, looking at those different capital budget items that we have with the Bank of Montreal and Epic, we're still in a struggle situation. All right, let's talk a little bit about where are we at with our advocacy group. So just to remind everybody, our advocacy work meets every week. So that's our PAC West lobbying group. Also with UFCW. And we have put together a plan that we're going to take to the state next week. So next Tuesday, Doug and I and Gretchen are going to meet with the OHA director for the sole purpose of ask her to get us on the board to make a one-time request of a $10 million cash infusion. The rationale for that is, as I just mentioned, we want to try to bridge, if we possibly can, between now and next July 1st to help us make these different changes and modifications that we need to do to the operation. Later on that Tuesday afternoon, we're going to have a larger discussion with the state treasurer's office, several of the legislators, and the Oregon Health Authority. And we're going to ask for several different items. One, the number one list, we're asked the treasurer's office to actually refinance our BMO bank. So that we'd actually get our interest rate down, as well as not have a private entity that we have to report to every couple of weeks. Secondly, is we're going to ask them to support in legislative action in February to issue lottery bonds that the state could actually issue that would extinguish our debt completely. So that would be a request of 45 million in lottery bonds, and the legislature has that authority to do it. And then the third piece, which is probably a little bit more of a stretch, is to actually have the legislature change how we get paid for Medicaid. That would actually increase our rate. So those are on all different stages. I think the cash infusion and the refinancing are probably the most critical, because that would give us a little bit of breathing room as we try to make all the changes for operations. All right, let's talk a little bit about away from just revenue cycle and cost, but how we can grow our business, because long term we have got to increase our volume. Now I will tell you, there's a lot of busy numbers in here, so I guess I don't want to apologize for it, but I think it's just to kind of give you a grasp of where we're at. We haven't really made much progress, since the last meeting, possibly doing a local health system. That's in preliminary discussions. There's no determinations made on that. So we'll kind of see where that goes. So this is our socioeconomics that we shared a little bit. Some of the challenges that we have is our population growth. Our population growth is only going to increase based on this over the next 5 years of 1.5%. So it's less than 1,000 people. You look at the state of Oregon, it's growing a little bit over 2.5%. That makes a big difference. So we're not going to grow out of this. Like everybody knows about our median household income, we're about 30% below the state, which obviously puts a little bit of a challenge on payer class. This is on payer class, and again, I'll try to emphasize that some of these data points have different bases of how we're looking at it. So I was trying to give you a picture of different models. So this is by gross revenue. So gross revenue, the big bucket on the left-hand side, the 55.76 is Medicare, whether it's straight Medicare or Medicare Advantage. Over to the right, the 21.08, that's Medicaid, whether it's open card or from the CCO. And then our commercial business is at 14% or 13.99. This is market share by discharges for calendar year. Discharges by calendar year. This is the entire market. So primary service area, which makes up about 80% of our discharges and 20% from secondary. So we're at a 68% market share. Riverbend, Peace Health is at 9.9. OHSU is at 4%. Bandon and Coquille are at 3.9%, and everybody else is something below that 3.9. Now here's a little bit different twist in regards to service area. So this is market share calendar year 2024. This is primary service area only, so it's 11 different zip codes, and this is based on charges, not on discharges. So at the bottom is the total market for inpatient only. This does not include any outpatient care. The total market is $470 million in gross charges. We have about a 50% market of that, or about $235 million. Peace Health has a 19.8% market share, OHSU at 10%, McKinsey-Willamette at 5.7%, Bandon at 2.1%, Asante down in Medford at 1.9, and Coquille at 1.6. Now, there's a lot of different information that says, all the good payers are going out of town. I'm not sure we've all heard that. So here's our reality. When you look at commercial, and that's in the middle column, our overall commercial business is 9.4. And Simon, I think you're right there. The total market is 11.5. Now, each 1 point of this market would generate about $4 million in additional revenue. Interesting enough, you look at Peace Health, they have about the same commercial type of business. Interesting enough, OHSU commercial is 20.8%, McKinsey-Willamette, and the other hospitals will see what it is. So yes, some of the commercial business is going out. It's not like everybody that's going out is commercial. That's just not accurate. We have a 60% of our market, is Medicare. The overall market is 58%. And then Medicaid, this is a little bit different than our gross. We're at 22.6, and the total market is 21.9. So we have slightly more Medicare and Medicaid business. Now, this is a lot of data. So this is market share, also by total cases by service line. So the service line, and we've tried to break it down into 9 different areas where there might be some potential. So again, when you start up on the left-hand side, you'll see where for cardiology, we have the total number of cases. I'm going to have to look at my own sheet here because that's a little bit far from me, so bear with me. I think that's 1255.
Yes.
1250, very good. I can skip the ophthalmologist this one. So you look at that, you know, we're at 72%, which is a pretty healthy market share. But then we also broke that down in the left-hand column. You'll see where it says commercial. So our commercial business is 6.6. The overall primary service area is 70.5. The next line is orthopedics, where we actually have a 50.6% market share. And you'll see that that Peace Health is our biggest competitor. But I think probably even more concerning is from a commercial basis, we only have 5.6 of the commercial business for orthopedics. The overall service area is 12.5. So there's an opportunity for us there. Neurosciences, we're at a 55% market share at about 9% commercial. The other market's 10. You look at kind of a catch-all for medicine and infectious disease, which is the largest category of patients. So there's a total number of cases of 2162. We're picking up a 70% market share, and you look at our commercial business at 8.4, and the service area is 8%. And then just kind of hit, pulmonology. We're at 74% market share with 4.1 commercial. That's mostly Medicare. Interesting, general surgery. We have a relatively healthy market share at 65.7. I think the interesting part of this data is that there's a larger percent of the market that's commercial insurance for general surgery. We're at about 15.6, and the overall market is 18.7. So again, I think the point on this is, yes, there's some opportunities of trying to bring some people back in town. The other thing to keep in mind that 60% of our revenue stream is outpatient, 40% is inpatient. So this is inpatient only. So that's where my sense is we need to go if we're going to grow the business. The only way we're going to grow the business is actually be able to recruit and retain additional physicians. So this is the particular recruitment needs that we have for the community. There's 39 physicians. Now, I want to make things perfectly clear. We're not going to go recruit 39 doctors. But the point is that there is an opportunity for selected specialties that we should actually pay attention to. Some of the recruitment needs we already have here, but some of these doctors are locums that we'd like to move into a different arrangement. So whether it's employed by somebody else or by the hospital. So my sense is, in addition to our revenue strategy, in addition to our cost saving strategy, we have got to grow the business, and we have to have a physician recruitment strategy. I don't think we've probably put enough time and effort of how we're going to go about this. So here's where I'm at as of today. We really have 2 different options that we go to try to recruit physicians. We can form a new corporation and actually set up our own company and actually have our own clinic that we would employ physicians. Or we can partner with Northland Medical Center and Bay Clinic. We have already started very, very early discussions with both the clinics of possibly working out some type of partnership. That would be our preference, is to work something out that makes sense for our partners at the 2 clinics that we can actually recruit to and retain doctors. So that's going to be a multi-month process. But I think keep in mind that if we're going to solve this out-migration issue, we have got to have some more physicians. All right, I'm going to change pretty dramatically for you because I want to make sure that whatever we do, and if for some reason we're not successful or we have some different headwinds, we need to have a plan B here. So this is going to be a very interesting conversation when we go out to Portland on Tuesday to talk to the state. So not to get too detailed on it, but within the state of Oregon, there's different hospital designations. You can be a DRG hospital, diagnosis-related group, which that's what we are. You can be a type A hospital, and if that is less than 50 beds, excuse me, and you're greater than 30 miles from another hospital. If you're a type B hospital, you're less than 50 beds and there's a hospital within 30 miles. Or a type C, which you have greater than 50 beds and you're on a referral center, and you can be a hospital district. Now, if you're an A or B, you get better reimbursement for Medicaid. I would say it's very similar to critical access. You're going to get close to Medicare rates, and that's the way the state designates it. During our advocacy discussions, especially with our legislators, the one thing we keep hearing over and over and over is, well, you know, I have different hospitals in my district, and you know, everybody's struggling, so why are you guys different? So here is why we're different. We are the only DRG hospital in the state of Oregon that's a health district. Every other health district is a critical access hospital. We're one of 2 DRG hospitals that's not affiliated with the system. So you guys might came from Roseburg, that's part of Common Spirit. They're a $34 billion company. Providence is how many billion? OHSU budget is how many billion? Peace Health is how many billion? Samaritan, how many billion? Legacy, how many billion? St. Charles, how many billion? We're a $240 million private public entity. We are one of 2 DR hospitals that does not receive any enhanced payment for Medicaid during the wage index. The other DRG hospital that's not affiliated is Sky Lakes and Klamath Falls. Well, since they're so close to the California border, they get a wage index for Medicaid that's based on Northern California rates, which is about a 15% bump. We don't get that. That's several $1 million. We're also a district hospital that does not receive any tax dollars from the district. And then probably the most interesting part of all of this is we're the only DRG hospital that has not 1, not 2, but 3 critical access hospitals within a 27-mile radius. So that's a very, very unique situation. There's 2 hospitals that are critical access that are close to St. Charles. However, they own both of those. There's a critical access hospital close to Rogue Valley. That's a DRG hospital. That's a national. They own them. So we are unique. We're very unique compared to anybody else. So here's the issue that I want to bring up. And I want to make sure I'm crystal clear on it. I'm not advocating that we do this, but I am bringing it to the board's attention that we better have a plan B if for whatever reason we're not successful. So this is kind of walk you through it. So if our financial performance continues to deteriorate, the expense issue continues, our revenue drops, our volume drops, you know, different funding mechanisms. So our financial performance, we continue to lose millions of dollars. That's one of the issues. If we do not receive any help from the state, back to refinancing the debt. If there's a cash, we can't get a cash infusion. They're not willing to issue any lottery bonds, and they're not going to redetermine Medicaid payments. That's going to put a lot of pressure on us in regards to generating enough positive cash flow. The Bank of Montreal can call the note if they want. There's no indication that they are, but they always have that option. St. Charles has indicated that they want to work with us, but they do have the opportunity if they want to terminate the Community Connect in about 1.5 years, that they have that option to do that. The Epic migration of the $22 million that we actually have to fund that. We can't get a grant or we can't get any assistance from Epic. If indeed many of our high cost capital needs that we have to replace that now rather than later, whether it's 4 million, 5 million, whatever the case may be, that's going to put a very big damper on us from a cash basis. And then if we're not successful in recruiting positions to try to grow the business. So let's say any or all of these combinations that we continue to deteriorate, we would have an opportunity, if we elected, we can elect to go to a type B hospital. That would mean we would have 50 licensed beds. In our discussions with the Oregon Health Authority, psychiatric services is exempt from the licensed bed requirement. So technically we could be a 63-bed hospital. Now remember, if we went to 50 beds and a type B, it would enhance our reimbursement. We have not run the financial scenarios. We have not built a model for this, but we will need to do that over the next several months. So if indeed we did that, and again, I'm not saying we're going to do it, but this would be, we have to look at every single service line from closing it or reducing the services. So whether it's APU, whether it's ICU, whether it's cardiology, whether it's OB, whether it's medical beds, everything would be on the table. Now, what we have come up with in regards to our plan right now for reducing costs, we are not suggesting that we reduce any service lines at this time with the exception of the Employee Wellness Center. And we did a quick return on investment. Actually, it would cost us less for the employees to see their primary care provider than come here. We are going to keep APU open at this time. We will reduce their cost structure, but it will stay open. But if indeed our financial situation deteriorates, we have to come back and look at all these different service lines, but we're not advocating we do it at this time. Because remember, I'm back to, here's our 3 goals. Make sure we save the hospital. Make sure if we can find a local solution, that's what we want to do. And then try to keep as much financial sustainability. I want to emphasize our cash issue, I would say, is more important than our operating margin right now. So we've got to retain our cash and try to get that moving in a positive direction for the next several months. All right, happy to answer any questions.
Thank you, Kelly. That was a lot of information. Does anyone have any questions for Kelly on this? A lot to digest.
Oh, it's very sobering, but it's also well presented, and we had a chance to see this yesterday, so we've digested a little bit, but
Thank you.
And that report will be available in the packet when you release that, correct, Denise?
We can post this on the website.
We can post it. So that'll be available for everyone that wants to see it, because that was a lot of information. Thank you. Yes, thank you. Well, if there's no questions from the board on that, I will move on to the tax levy education session that we've asked our attorney Megan to give us. Red is on.
Oh, I see.
Oh, no, it's off. No, it's on. No, it's on. Hold for 2 seconds.
Is it on?
No, now it's on.
Now it's on.
Okay. So we've always had some inquiries about pursuing a public option levy since we don't have a permanent rate. And so I've talked to him and I'm starting to look into it. Well, I've been looking into it, but we run up into a bit of a roadblock, whereas the Coos County assessor really doesn't have any information for the district. They stopped keeping it back in 2009 through 2010. So it's kind of a piecemeal approach of going through the different area codes that are within our district. Their computer program doesn't just automatically let us know. So it's just an update, but that's something we're still pursuing to try and look at the inquiries, but we don't have a lot of information at this point. So we're trying to figure out if we can get a better idea of a specific numbers and take into account compression and so forth. So
To clarify, we're not pursuing anything. We're just looking at it so that we're
investigating. No, we're not pursuing anything now. We're just investigating to see what the numbers would be. But at this point, we're kind of up against a roadblock unless we can get some information, because it's not, because we don't ever levy a tax. They stopped tracking that information about 15 years ago. And it doesn't coincide with any of the other districts exactly. And so we're trying to figure out that information. So.
Thank you. Any questions on that, Megan? Okay, with that, Patrice, we will move it over to you for the quality and safety patient committee summary.
Okay, our last meeting. Can you hear me?
Yes, we can.
Okay. We had a lovely presentation from Gary Salcido, presenting for the Joint Replacement Center. He included a lot of data and outcomes and different achievements that they have been able to acquire. They're doing a really good job with the patients that we have. It'd be nice if we could get more patients in the Joint Replacement Destination Center. We also reviewed our 2025 CMS star ratings. We are hanging at 2 stars for the second year in a row. A lot has to do with this, but it's basically based on what's called HCAHPS, our hospital consumer assessment. And those are the questionnaires that the patients get and then turn back into the HCAHPS system. Once they've been admitted to the hospital, then they get an assessment that they can do. And unless you get 5-star, meaning something happens always, like the nurse always communicates effectively about the patient's drugs on discharge, we get a lower grade. So for the second year in a row, we are only at 2 stars. It also depends on the volume of replies after those have been sent out. So I wish I could give you better news on that. Our readmission rate has also been a priority, and it is an opportunity for improvement. We are working right now primarily with some of our heart failure patients to improve the fact that they aren't being readmitted within that 30-day discharge date. Kelly, I can't see who's there.
Yes.
Is Kelly
She's
down
here.
there?
Yes.
Okay, Kelly, can you explain about the federal fiscal year 2026 CMS final rules, please?
So annually, CMS updates the rules that we operate on, and they publish a final rule. And the most significant changes we're going to see on the quality side for the final rule. Typically, when we measure our performance and quality for CMS programs, it's straight Medicare patients only. That's the only denominator group we can look at. And that's in this final rule has been expanded to include all of the Medicare Advantage plan. So more of our patients will be in that denominator. One of the things that's going to help us when we look at our star rating and some of the value-based purchasing, the data runs on a 3-year rolling period, and that's going to be shortened to 2 years. And that'll be helpful because prior poor performance is going to fall off quicker, and it'll be more reflective of what we're doing in the moment. And then COVID has been denominator exclusion in a lot of our performance measures, readmissions, mortalities, sepsis fallouts. And that, we've been playing in the COVID space long enough that is no longer going to be a denominator exclusion for us.
Thanks, Kelly. That's our report.
Thank you, Patrice. Any questions for Patrice? I got to attend that meeting and it was very lengthy and lots of engagement. I encourage you to attend that meeting as well. All right, with that, we will turn it over to Doug for our finance report.
Good evening. Do they have the resolution? So first item tonight, record keeping. So you'll have a resolution. We were informed
Original resolution. This is the
by our advisors at Deschutes Investments that we still have the former CEO and CFO as signers on our accounts. We just need to remove that, clean that up. So that's what you have before you as a resolution.
Perfect. Okay. Do we need a motion for this?
Yes.
Yes.
All right, can I get a motion to accept this resolution?
So who becomes the signers? It would be our interims?
No, it would be Gretchen, which Gretchen, you're already on there, right?
Already on there, but
Yeah.
they didn't take them off.
Right.
Additionally, Karen or Simon, you're
Simon.
on there.
Kyle.
So we.
Yeah, we just need a motion to remove the former CFO
And CEO.
and CEO.
I move to approve the resolution as presented, removing the prior CFO and CEO.
I'll second.
Motion and a second, all in favor?
Aye.
Aye.
Any opposed? Motion passes, and I will sign this after. Thank you.
All right, so just going back for July and summarizing, since we had the finance committee meeting a couple of weeks ago and went through it in depth. Tonight, I thought we'd just give it a quick summary. So for the month of July, we lost $2.3 million. And how did we get there? Inpatient discharges were below budget by 9%. Our average length of stay, actually a good sign, was down to 3.75 versus a budget of 4.77. So those combined to reduce our inpatient days by 448 days. So that led to a 3.4 million or 11.9% reduction in revenue for inpatients. Outpatient services, the visits were down 10 visits on a budget of 11,317. So pretty close to budget. Revenue was up compared to budget, though 1.2 million, and that's related to service mix. So we had more activity in the cath lab, surgical services and emergency, which has higher revenues than, say, general radiology or the lab. So net patient revenue for the month was 966,000 below budget. Expenses, salaries, benefits, and contract labor combined were 1.4 million, or 12% over budget. Our FTEs were up 6% or 54 FTEs. Physician and pro fees were over budget, 41,000, about 3%. Supplies under budget by $8,300, so pretty much right on budget. Leases, rentals, depreciation, and other operating expenses were over budget, a combined 198,000, and that was driven by an increase in our provider tax, 265,000. So operating expenses were 1.3 million over budget. And so the combination of the lower revenues and the increased expenses brought us to the $2.3 million in losses compared to a budget of an $88,000 loss. I'll stop there for a second. Looking at it, our budget is built on an extremely high volume expectation. I think as we move through the financial sustainability model, we will recast the budget and put things back into something that's probably a little more realistic than what you're looking at right now.
The budget that was previously prepared, was it based on any specific percentage increase, or did we pull it out of thin air?
I don't know. But to be off by 400 plus days, I mean, that's 15 plus average daily census that we're off. I think the numbers appear inflated. So people want to bring those into line so that we have something a little better to look at. Plus, we'll change all the productivity measures so that we can keep a tighter rein on the budget.
Doug, are you suggesting that they did not use prior volume data from the previous years to project this year's budget? This was just, like you say, pulled from thin air?
They used previous data and they projected volumes have been down for the month of July. What were two, July and August. And so it could have been a spreading issue. I don't know if because the total increase in discharges wasn't significant for the whole year over the previous year. But usually what the process was, they would look at the previous performance and project. Without hiring new physicians to the market, there was no new revenue or new business to capture. So there wasn't a whole lot of increases built in, but we have seen some decreases. I'm not sure of the total though for the year.
Thank you.
So also continuing on for the month of July, we did not meet our debt service coverage ratio, days cash on hand, or liquidity measurements for our loan with BMO. So that continues to be an issue. We also discussed QDP. So those directed payments are merely a conduit for us to get our provider tax back that we paid out. Nothing more than that. And then lastly, we looked at going forward, having a report on denials by type so we can track that as well. And that's the summary of July. Any questions?
I have no questions. Anyone else? Thank you, Doug. All right, with that, it's the board comments. The only thing I have is to the executive team hosted a employee forum. We hosted 4 of them. It's my understanding in the past we host somewhere, and Denise, correct me if I'm wrong, somewhere about 7 of them. And from what I'm hearing, these 4 were attended by more than all 7 previous ones combined. Normally, these were standing room only in a couple of them. I was able to attend all 4 of them, and it was exciting to hear the feedback from the team. There was a lot of staff members that came to me personally afterward, thanking us for hosting them and thanking us for having the blunt conversation. And so I just want to thank the executive team and everyone here for putting that on and being available to answer the questions. It was also reported to me that there was more questions asked at this meeting than anyone in the past. So I was very happy to have that. Kelly, you did a great job. Mel, you also did a great job. Thank you so much. Mel played our, I don't know what it was, but you jumped all over the room and everyone loved it. So I was very appreciative for those employee forums, and we got some feedback, and I'm sure we'll do more of them. So I just want to thank you guys for hosting those. I will turn it over to the rest of the board for any comments or questions. Dr. McAndrews?
Make a comment.
Oh, you've got it.
I don't want to nibble this hospital into bankruptcy, but I think the board should have a bottle of water, a sandwich, and a candy bar.
All right. Noted.
I just wanted to comment on the report that Kelly gave showing the commercial payer impact. I haven't seen that data before. Looks like our opportunities are maybe in general surgery and orthopedics, if I read it.
And oncology.
Yeah.
And oncology.
Yeah, very much so.
That's useful data.
Yeah.
To know where we lead and where we don't. So thank you.
And I will just add that I have seen the work that the executive team, well, not just the executive team, but everyone that has went into this new budget restructuring, or however you'd like to call it. I mean, they have literally went through every piece of this hospital. There's no stone unturned on this campus, and I just really appreciate it. And I appreciate the transparency to the community. And I apologize to some of you. Your emails went to my spam, so I'm checking spam now. All right, that's all I have. Kyle?
No,
Brandon? Patrice?
No, I'm good. I'm just, still trying to get through all the information and think about how we're going to move forward. And I'm hopeful and prayerful that when our leadership team goes to Salem, that they actually hear our need.
Yes.
I guess, is there a way for the public to write letters to try to help this
help the case a little bit
I
more.
think that's fine. I think that the best is just with our local legislators is the best way. Because a lot of this is going to be legislative action
Help them full of letters.
with Anderson and Boomer and all, yeah.
Maybe we can see if our lobby group can help us come up with a guide for addresses and kind of a template.
And that actually does bring me to one comment that we got over and over at the board meeting, or excuse me, the staff meeting, staff forum. I couldn't think of the word, I'm sorry. The staff forum was, how can we help the staff? We heard that at multiple of them, and I think that the answer that we gave them is the same answer that we can give to the community, is that we really need the community rallying behind us, and that we're all in it together, and we're all here to work together to see the hospital succeed. So the community, you know, if you, I mean, I've seen a negative review on social media, you know, those things, or even positive, those being shared with us and being brought to the executive team, it helps us address them. So as the community being a cheerleader for us and helping us be better is extremely important. With that, I'll close the board member comments, and we will move on to Dr. Atlery with the medical staff report.
I'm so sorry for being late a few minutes today. My report is actually very brief this month, but just wanted to let you know that the volumes are up. We did notice a small uptick in August, but definitely this week it's been busier. And we are definitely all happy about that, because I'm sure it'll reflect in numbers too. Our hospitalist executive team has interviewed 2 candidates for the CMO position. It's part-time position. And I think in the next few days, we'll make the decision as to who it would be. I think it'll help a lot with the medical staff office obligations, and also making sure that we're compliant with all the accreditation bodies. In an effort to actually bring the physicians, providers, ABPs, everybody together, and that's just not in the hospital, but also in the outpatient, like NBMC, Waterfall, like all the outpatient clinics, even Coquille Valley Hospital, Southern Coos, SWAMS, which is Southwest Oregon Medical Society, hosts a fall picnic. And it's announced, and it's this September 28th at Ferry Road Park. So everybody, you know, who's in the medical field can, if you have not received the invite, please feel free to attend. We do have now 2 full-time rad-oncs, I think, and I think it's going to help, but unfortunately, not so much on the inpatient side, but on the outpatient side to actually continue to provide services with limited interruptions. The only reason I mention inpatient is it's not reimbursed service, so it's impossible for us to, like, you know, get the patient, you know, get discharged every day and again readmit. So some hospitals are able to do that, but unfortunately, we are not able to. We are hoping to kind of build the outpatient and oncology service with the Eagle, the telehealth, to the point where they can also continue to provide inpatient coverage, and hoping once that's more established and stable, we'll be able to restart the inpatient chemo starts again, which I think will also generate a lot of money. So happy to take any questions. One request for the public is, you know, I think, you know, probably everybody had already seen the Leapfrog survey, and we didn't do very well. It's a lot to do with the, you know, patient experience, the perception. And I think it also does actually play into when the executive team does reach out to the OHA as to, you know, how the public perceives it. So we're happy to take feedback as to, you know, any constructive feedback as to how we can do better to improve that. And I don't know if the previous perception of the public with the board elections and all had a role in how poorly it all turned out to be, but we'd be interested. So if you have any feedback for the medical staff, please let us know, and we'll definitely take it seriously. Thank you.
Thank you, Dr. Atlery. Any questions for Dr. Atlery? Okay. Thank you. We will move on to the next item on the agenda, which is reviewing the policies and procedures for hiring a CEO. We already have those policies and procedures adopted. I believe they're being posted up here on the screen, and you should have them in here. I've already seen them. Is there any, and everyone should have them. Is there any questions about them?
Please open a public input session in case the public has any comment.
Yep, I was gonna move to that one. I just wanted to see if any of the board has anything. And with that, it's required that we have a public input session specifically on this topic. So if anyone would like to have any public input about the policies and procedures of hiring the CEO, please step up to the podium. And we also have one public comment that is.
He had to leave and doesn't think he'll make it back, but thanks.
Okay. Any comment on this item on the agenda?
I don't have the full information about it, but I understand the state of Washington has now requires the CEOs to have a license to something of that sort.
There was
Where
some legislation about that, but
legislation about, do you know
I don't
if
think it
Oregon
did
is
pass.
participating? I'm not sure if,
I think it was proposed.
yeah, it was proposed that I think they should have licenses so they can review. I don't know if Oregon was actually following that, but just thought it.
I didn't hear that either.
It's definitely discussion across the country that CEOs need to be some sort of certification, just like doctors and nurses, since they're running hospitals. You guys shouldn't be able to just do whatever you want.
And we don't.
Sort of, yeah, I think they were planning to actually, license them, and so there's some supervising body.
All right, no comments on that. I will close the public input session and move on to our executive session, which requires everyone to leave the room, and Megan will read us a wonderful statement.
So before we go though, do we want to give them an estimated
Oh,
timeline?
yes, sorry, just to mention it to everybody, the only item on the agenda after we come back as of now is a credentialing report, the action item. So we'll be in executive session for at least a half an hour, I would assume, at least. But again, there's only one item on the agenda afterwards. So if you'd like to stay, you're welcome. But it won't be too exciting, in my opinion. Yeah. Thank you for coming. Yes. Now you are, yes.
I am, okay, thank you.
Yeah.
He's opening down.
Board of Directors for the Bay Area Hospital District now meet in executive session pursuant to OR.
Yes.
Record on here, we need Tom to say.
Thanks, Kelly. I can hear now.
So we are back from executive session and we are moving on to the credentialing report.
Because I'm being considered on the credentialing report, I'm recusing myself.
You have a conflict of
I have a conflict of interest and therefore I will abstain. Thank you. We need coaching.
Discussion, yeah.
Perfect, thank you. So with that, can I get a motion to accept?
I'd make a motion to approve the credentialing report. I'll
Thank
second.
you. We have a motion from Kyle and a second from Brandon to accept the credentialing report. Any discussion? Any discussion on that? So we have a motion and a second. All in favor?
Aye.
Aye.
All opposed? All abstaining? Perfect. Motion passes. And with that, our next board meeting is on October 14th and it's 8:09 p.m. I'm adjourning the meeting. I remember the gavel today. 8:09, yes.
Good night.
8:09?
Huh?
The meeting is gonna be at 8:09?
No, it's currently.
It's 8:09.
Yes.
Ending our meeting.
That's cool.
Yeah.
He didn't finish here. Like you said.
Oh, no.
8:09. Well, that's a late meeting.
I gotta sign these for Denise.
Why did?